Good morning. It's another episode of Insight. I'm Crystal Legends, and I'm joined today by Dr. Ross and Dr. Downs. I'm going to let you guys introduce yourselves a little bit. We'll go with Dr. Ross first. Tell everyone how long you have been with the hospital system here locally in Onslow.
So I've been with the hospital system for 3.5 years. Mm-hmm. I'm a board-certified radiation oncologist and was brought here to help elevate the level of oncologic care in our county and surrounding community.
Dr. Downs, how long have you been in this business and as well in Onslow?
I've been in Onslow for only about 6 months. Mm-hmm. I'm a local of Eastern North Carolina, so coming home to me was about 5 years ago to work in this community.
And what are your specialties?
So I'm a board-certified general surgeon who did extra training and specialty in surgical breast oncology. So I'm the breast cancer surgeon piece of the multidisciplinary board or team that usually assists in all breast cancer cases. My specialty is breast reconstruction. Mm-hmm. That's my happy place. But and also just whatever surgery we choose, I want women's breasts to look exactly how they want them, whether that's to be untouched or whether just to get the cancer off their chest, whatever makes them happy. And so my specialty is breast cancer surgery.
So take a minute and discuss radiation therapy as a form of treatment for breast cancer for us.
So essentially what's happening is you take something that appears like a small pencil or pencil lead and aim a beam that exits from a machine mounted in the floor to target where cancer cells were or are in order to kill those cells and allow healthier tissues to heal and repair, renewing the body.
Okay. What kind of process could patients expect? Like, how are they going to feel? Is there much downtime to those sort of things?
So in total, although each of us physicians like to think we're the last Coke in the desert, the reality is it's spokes of a wheel. So you're the center spoke with a variety of units that help TLC the patient. Mm-hmm. So a patient comes in for consultation, typically after a biopsy is known for the diagnosis, where Dr. Downs comes in for that information. And then the patient is seen by myself and the appropriate personnel. After consultation, they're put in a planning position known as a simulation. And that way we're able to target and create the plan based upon their gorgeous anatomy. And then we send everything to the computer system, customize the radiation based upon their body dimensions. That's what helps reduce the amount of time the patient's in the clinic and the amount of time the radiation beam is on. This is markedly different from 26 years ago when I started.
I was going to say, there's a lot of advancements that has happened.
Beyond. The same way 26 years ago, you didn't have a flip phone, a cell phone, a smartphone. Sure. Now we have smartphones, maybe with dumb people around them.
Yeah.
You know, myself included. It's the technology has really elevated in such a way that it's more pinpoint accuracy.
Mm-hmm. That's fantastic to know. I know a lot of people, there's a bit of a worry, a stigma of what it will be when they go in, but it does seem like it has advanced drastically to where, the treatment is just quicker. How do you guys usually support patients emotionally through the process?
You want to target that one, Nick?
Yes, we actually have a wonderful woman. She's a nurse navigator. Her focus is on breast cancer. And so usually you'll have an appointment with her at some point through this process. And we also have ancillary staff who are available to work with social work, with, cancer-related depression or anxiety or just anything that you're feeling through this roller coaster of emotions throughout the entirety of this process. And so we usually screen people with a distress screen to determine if they need that. Oftentimes it's pretty obvious.
I was going to say, do people tend to take it well sometimes?
Yes, actually.
Really?
I mean, this is
That's
why.
impressive.
I know about Dr. Ross. This is why I chose to specialize and work with women. We are resilient, and it's amazing. And I'd rather work with a group of women who are just ready to fight and who don't complain, and they have their lives, their children, their families to work with.
Right.
And so it's usually pretty obvious with them. They'll tell you. They're straightforward. And so we have definitely a lot of different available options to help them through that process.
That's fantastic. Yeah. So speaking of different types of processes, there's several different kinds of surgeries that can happen when you do get a diagnosis. Tell everybody a bit about those.
So I'm a board-certified general surgeon. So I did general surgery first and then specialized for a year just focusing on breast cancer surgery and oncologic surgery. So surgery is a very complicated usually option for people to go through with me, but I do my best to walk you through it. I usually say there's 2 major options, one of which is breast conservation. That means removing the badness out of your breast, leaving the rest of your breast behind. And then the other is mastectomy, and that means removing all of the breast, because there's 3 flavors of that: going flat, reconstruction, 2 different types of reconstructions.
Okay.
And so based on your particular case, your body, your anatomy, your comorbid issues, like smoking is a big one for me, we can talk about what's available to you. And no matter what you choose, as long as it's oncologically safe, I'll offer it to you.
Okay.
I want everybody to think about a year from now, when you're looking at yourself in the mirror, I want you to be happy with what you see.
Right.
And I'm not here to determine what that looks like. You tell me and I'll give it to you.
That's amazing.
If it's safe.
Right, as long as it's safe.
Yeah.
And speaking of, you said there's a couple different types of the reconstruction. What does that process look like? Because that's a long process. It's not a quick fix like some might hope in their minds.
That's true. I usually prepare everybody with how long it takes. The surgery itself takes me several hours.
Sure.
Depending on if we're doing direct implant reconstruction or if we have to do tissue expanders, which are just balloons in which I can change the shape, the size, control some other factors with the skin flaps that are left behind. But usually it takes me about 4 weeks of recovery. And if you need a second surgery, we go back to surgery at that time, and then you start the clock all over again.
Okay.
So usually in a good 2 months, you'll start feeling normal again. But 6 months really seems to be when most women are like, I'm great, this is wonderful. And
So 6 months really, what does post-surgery look like? Do we need to not work? I mean, how long does, you can't pick up your kids because you can't typically pick up over 10 pounds for any surgery. And this is quite a significant surgery.
so the lumpectomy surgery, you don't have a ton of restrictions.
Okay.
Usually it's just don't do any excessive movements like CrossFit,
Yeah.
jumping
Yeah.
jacks or jogging for the first couple weeks. You can usually go back to work in about a week.
Okay.
But reconstruction, there's a little bit more restrictions. So nothing over 10 pounds with your upper extremities for about 4 to 8 weeks.
Okay.
You can't shower because we have these drains in place. Really, the big goal with everything with reconstruction is avoid infection.
Right.
So I don't want you doing anything that causes infection, and we just watch you like a hawk.
So how do the two of you and other colleagues that you have, how do you guys typically collaborate together in this process to, ensure the best outcomes for your patients?
What I'm pleased about, actually slightly seasoned in age compared to Dr. Downs, is there's been a huge transition of what I would call paternalistic care, where we tell you what to do, to where we incorporate the entire team along with the patient.
That's
so
fantastic.
What I'm grateful to her for, and her transition here to Onslow, is the fact we collaborate on each of our patients. She either calls me, I call her. We literally collaborate before the patient has any type of treatment modality. So what I'm grateful for, and what I find most of our ladies are grateful for, is the fact that you talk to her or she talked to me, and they'll say that in a question way because that doesn't always happen.
Right.
And I'm really grateful to have a colleague that I can trust who has integrity and character. And really what she said is what she wants to do. She wants to give you the best outcome possible, the highest cure. And what are you wanting to really look like a year from now, 5 years from now, 10 years from now, when we're going to be distant memories? This is a pothole in your life that you got to patch.
Right.
And then when you get over, you're like, oh, who were those 2 people that helped take care of me? And that's the goal that I know both of us want. So the fact that although our paths have crossed serendipitously, both of our passion and purpose are aligned in the same concept, we're able to work collaboratively together and speak in an honest way of saying that this would be my reservation, these are my challenges, this is what the patient conveyed to me. Because sometimes as I have found even with my nursing personnel, patients will say different things to different people as it's unfolding in their brain. I mean, this is live.
They're thinking
Jessica,
about
we
it
are
as
live.
it's happening. Yeah.
And so all of a sudden, what wasn't conveyed to the surgeon might all of a sudden be like, oh, I told the radiation oncologist that I really want X, Y, and Z. And so it's not punitive to the colleagues that we're working with. It's saying, I don't know if they mentioned this to you at the time when they were overwhelmed with the diagnosis, that they're even sitting there, and then everything goes blank.
Right.
A day or two later, now things are trickling down in their abacus of questionnaires.
Sure. I can't imagine how comforting it is to the patients to know that you guys are collaborating and the way that you guys do it. I know that's got to be so comforting.
Not only are we collaborating, via text or phone calls, we do have multidisciplinary team tumor boards.
Right.
And that is the key. I mean, that is a national standard that any place that treats cancer needs to be able to uphold, and we do that as well. We meet on a weekly, biweekly basis, depending on the cases in which we have, and everybody talks: radiation oncology, medical oncology, myself, the radiologist, the pathologist. All key players talk so that not a single thing is missed in your care, and that the best decision and possible options for you are presented, and everybody's on the same page. We get to talk about research opportunities. We get to talk about, is this something that needs to be treated at Onslow? It's very rare, but it does happen, in which certain pathologies would be best treated at a tertiary care center.
Okay.
And we do not scoff at all at saying this would be better served for the patient's health benefit, prolonging of their life, to send them to a tertiary care center. And so that also is a key part of what we determine is the best treatment course.
Correct me if I'm wrong, and I know you will. I typically, at what age do they start screening for mammograms? It's in your 40s, right?
There's a couple trains of thoughts, but generally the one that I follow through with is about 40 years old.
Okay.
Is when the average population starts. Now, we usually like to push people knowing their family history. Is extremely important to determine if they're what's called high risk.
Okay.
High risk patients will start significantly earlier based on how high risk they are, and the screening is extremely different.
Okay.
But on average, I'd say if you start at 40 with no family history, you're probably within the average population.
Okay. And early detection, I mean, what does that look like? It's so important to, I think that, I don't want to say back in the day, but, the self-exams, the home exams and things like that, they used to be pushed a lot. And I don't know typically now if people are doing that as much. I think people do rely on the technology of they say, I'll get a mammogram when I'm 40. What should we be doing if we're younger, if we're in our 20s, in our 30s, at home to make sure that we're being preventative or at least very aware?
I say you know your body best, okay? And that starts from as soon as you can recognize the fact that there's something going on.
Something's different.
And I suggest to everybody that you should at least feel your breast, your chest, your neck once a month. I'm not saying that that's definitely going to save your life or you're going to pick up something. But if anything abnormal is present, just make a phone call. I'll see you, the primary care doctors, OBGYNs. I'd rather be safe than sorry. And usually, I don't know about you, but it's a large number of women who say, I felt something different, or my husband felt something different. And that's what started, that was the catalyst for evaluation. And
in our literature, they'll recite as high as 70 to 80% of any palpable lesions are first noticed by the female.
Yeah.
And generationally, those who are more seasoned in age are less likely to pay attuned to their anatomy. Those who are closer to the tree of life, if you will, tend to be much more aware. It's not a slam. It's just I've seen the progression of awareness. And as Dr. Down started out in the beginning, she loves working with women because they advocate for themselves. That's actually a true statement anymore.
Yeah.
Women are not going to stand by. And if they don't like the answer, they're going to seek, search, and find.
Yes.
So, you just don't placate or poo-poo someone's feelings or what they're sensing or noting. They're engaged and they're willing to advocate for themselves. That's a huge transition in that pendulum of seesaw.
Yeah.
Whereas before we followed what you said and now we're like, we're the commander-in-chief.
Yeah.
So let's get on board, right? And that's really galvanizing.
I think that's powerful because that is, and like you mentioned, and then it's not a slam for anyone that doesn't have children or anything like that, but I do know if something were to happen to me, that's my motivation to keep soldiering on. That would be my, no. We're going to take care of this. Because you got things to do, and women are definitely like that. What are some resources that you feel people watching should be aware of?
Locally? Well, obviously utilize your physicians,
Sure.
no matter who that is. It doesn't matter if you're into the orthopedic doctor for your knee and you're like, I felt something weird. Anybody can put in a referral, okay, to your PCP or OBGYN, to me, Dr. Ross, whomever they think is easiest to get in contact with. We also have a fair amount, not enough, it's definitely understaffed in Eastern North Carolina, but we do have a fair enough of freestanding mammogram sites or ultrasound sites that, usually your physician has to write an order for.
Okay.
But those would be the first two, is definitely get into somebody who can direct you towards us or towards a physician who can start the process rolling of what's going on.
Sure. What advice do you have for someone who has either just found something that feels different, and has to make those calls, or someone that has just been diagnosed? Because obviously the two of you, are much more familiar and know about the process and statistics as far as, what's going to happen next.
So I would say, first off, if you do feel or sense or notice something, echo exactly what Dr. Downs said. Get into a provider as soon as you can. It doesn't matter which one. Get there if you can.
Okay.
Adams, right?
Yeah.
So at the end of the day, seek to better understand and know and determine. And then as far as the other pieces, call the institution and say, do you have a breast navigator? Do you have someone who can help direct me and direct that flow? We're very, very pleased and excited to the fact that we do have a breast navigator, and frequently, almost daily, come to me or highlight to Dr. Downs patients who have a concern, have an issue. It's less intimidating sometimes as opposed to calling a physician office in general terms. We had an incident this last week where a similar piece happened and somebody noticed, and they immediately, whatever in their cognitive skill set forced them to reached out to the navigator, who then expedited her care to
Wonderful.
Dr. Downs. So the point is now in today's modern world, you can Google a lot of things. You can social media many things. Call the institution and say, who's your navigator? How do I get plugged in? And sometimes it's a friend calling on behalf of someone else.
Right.
It's amazing how many times that Dr. Downs and I find, my friend told me this, and, I wasn't going to do this. I thought it was nothing, but it kept being present. So women are advocates for other women.
I love it.
And that's huge too.
Is there anything that, you think that we haven't touched on that you think is important for listeners and viewers to be aware of?
I think the saddest group of people, and I don't know if he agrees or not, are the people who notice something and ignore it. By the time they make it to us, usually it's a very difficult pathway for them. The reason that we push early screening, the reason that we push you understanding your family history, or bringing up the slightest, smallest, no matter how silly you think it is, change in your body, is because if we find it then, we can usually kill it enough to give you longevity of life that you're looking for. And so it just breaks my heart when I see a 20-year-old, a 50-year-old, a 60-year-old who's like, I've had this mass for so long, and now it's something that's completely out of control.
Right.
That breaks my heart.
I think to echo that piece of it, which really is profound, there's a subtle acronym in the word denial that says, don't even know I am lying. And denial can be a very powerful thing for any person.
Sure.
And to the echo of you asking and Dr. Downs replying as, what are some of the psychosocial pieces that you have available? In addition to that, although we're not psychologists nor psychiatrists, right, our aptitude isn't in that skill set per se, we can direct you to our case manager, our social worker, and work through some of the creepy, crawly critters that are inside your brain tissue that can be just as powerfully toxic based upon your traumas from whatever your life has been. Neither she nor I know the journey that you've taken, been through, or experienced by purpose or not.
Right.
And although we can give you the best technical care, some of the other non-clinical psychosocial care is what also feeds into your ability to have sustainability.
Sure, yeah.
And what I call not just a quantity of life, but a quality of life.
Right.
We can cure you in many instances, but then the harbingers in your brain tissue, the ghosts and goblins that are handing out their trick-or-treat candy, feed that negativity, right? And although in a softer flow of this, we talk about the disease, there are many people in different types of non-traditional medicine who talk about the dis-ease, spelled the same way. But what are you holding in? What are you preventing in the release that's storing up and manifesting itself in a different way and in a different expression. That's the real key to get in.
Yeah.
And that's the part that I think is important for us to connect you to the right resources, which equally are limited.
But
Absolutely.
also to echo what you're saying, I mean, cancer, especially breast cancer, does not discriminate.
Yeah.
And so I don't want people to think I don't have insurance, I don't have money, I don't have access, I don't have a car. It doesn't matter. We'll figure it out.
Right.
We have all of that available
I
at
love that.
Onslow to get you there, take care of you, get it covered. We want you to get treated. We want you to live.
I think that's the best thing. We'll
And
figure
it's
it out.
not just women. We do have, to her point, 2,500 cases a year, typically of men, which are always mental misnomers.
Right.
You know, and it's always interesting to me in our male colleagues who typically have less prodigious breast tissue and then can ignore something to the point where it becomes a stone. And then they're like, oh my gosh, I just thought it was X. You know? And then it is more locally advanced. And then I'm calling Dr. Downs and saying, hey, we're going to have to think outside the box. You know, this is person so-and-so, you know, and work through those avenues.
What are some things? October is Breast Cancer Awareness Month, and I think that most people know that, but they may not know about some of the events that you guys have going on. So what are some things that are happening around that?
So at Onslow, we do have a Miles for Mammo program and something called Julie's Pink Warrior, where during all the months, but especially October, which is Breast Cancer Awareness Month, we work to raise resources and awareness for women to have their imaging who are either uninsured or underserved in our community, so that, to Dr. Downs' point, there's no person that should find an excuse for not being able to afford, if you will, the luxury of mammogram or proper imaging.
That's
And
awesome.
Actually, at our Miles for Mammo event, we will be doing free screening as well. So myself plus my nurse practitioner and PA and whoever else is going to help. It's just another opportunity to have whatever you think is odd checked out.
And that's in October. Okay, perfect. Can they find it at your websites?
Yes, they can. We'll find it on our website, and then we'll post this at the end of the podcast as well, so you can link to further understand how you can get involved, engaged, even participate to help other women in your community. It can be as simple as $1 that can help contribute to someone's better health and well-being.
So walk me through a start where I've noticed something at home all the way to survivorship. I know every case is different, but typically, what does that look like?
So once a patient is diagnosed with a breast cancer pathology, then typically minimum is usually 2 months of the journey, which might include surgery and or radiation and or some type of anti-estrogen pill. It can take up to 6 to 8 months depending on the complexity, the level of stage, the severity of the disease, the age of the patient.
Okay.
So this isn't, although we work to make it a one-stop shop and done, where you're seeing the providers getting all of your information, the actual treatment journey really is your marathon in your life at that moment. It's your 26.2-mile race.
But we do a really good job here at Onslow at making sure that we can try to accommodate that one-stop, at least initial consultation or visit. So
That's right.
If Dr. Ross is the first person to see the patient, I have same-day appointments for any new cancer diagnosis or anything that he just wants me to look at.
That's incredible. Same day.
Our medical oncologist also saves spots for us if we give them a call and say, hey, you should see this lady. Hopefully we can get you seen within the same day or at least the same week. And so that everything can be done in Onslow, get you set up for whatever process it's going to look like, whatever your journey is going to look like. All of that can stay and be done within Onslow.
So speaking of it being Onslow and everything can be done in Onslow, I think a lot of people think, you know, specialties or certain treatments need to be done in these other cities. So tell everyone why Onslow? You guys really do have everything available right there.
We do, absolutely. Dr. Ross is like most radiation oncologists in the sense that they are trained in radiation of all cancers, and breast cancer in particular is our topic today. I am a little bit more of a rarity in the sense that there aren't a ton of women out there, or men for that matter, who do a specialty in surgical breast oncology. And then also the medical oncologists also are extremely skilled in breast cancer. To have the three of us all right there, unless you are an extremely rare special case, there is no need for you to have to leave your home, your community. I mean, this treatment process we were talking about can take anywhere from 8 weeks to 9 months. Depends on your particular type of cancer. And to have to drive to Raleigh or Wilmington or Greenville for that long is a lot to ask.
It's life-changing
If you
and
have
not in a good way.
children, if you have a job,
Yeah.
I mean, how are you supposed to do that?
Yeah.
And so we will always address all of that. And if we felt as though you would need to be seen somewhere else, we'll send you.
Sure.
But generally speaking, 99% of the time, you can stay home. You can stay in your community and get the best level of treatment.
I do think that's really important for people to realize is that you can do, like you said, with all of you right there at Onslow Memorial, you know, everything can be done here, because I think when you are going through something like this, at least from, you know, friends that I've seen, what you crave the most is the normalcy. You want to be able to go to the kids' game,
necessary.
or you want to go home at the end of the night and you know, be on your own couch. You know, you don't need the added stress of the back and forth.
Those components are just as healing.
Yeah.
We go to our homes and hopefully to have less stress and rejuvenation of our spirits for the next day, right?
Yes.
Always not a guarantee, but nonetheless our hope,
Sure.
right? And the same for our patients. We want that. I know Dr. Downs, what honed she and I together unknowingly was first and foremost our intention. And our intentions were aligned in the same way, although our specialties are different.
Right.
So when she says to me, I want to have the best outcome and do the least amount to get the most favorable outcome for cure and survivorship, that aligned with what my mission is too in the radiation oncology arena. So I typically see the caboose to her treatment, right? So a lot of times, and she's not the only surgeon that I work with, but she's the one my preference is for, because I do see the caboose, and ladies have a fantastic outcome.
That's awesome.
And they look better and feel better and are healing, not just physically, but mentally, because someone's listened to them and said, I hear you, I understand what you need and want to do, and I can surgically work to accomplish this in this way if you can lean into the trust. And that's powerful too. The fact that someone feels acknowledged and understood.
Yeah, that's not everywhere.
I can't make up pieces that don't exist. So our intention, first and foremost, is what's in parallel and concert to deliver great care in an exceptional way, aligning our passion and purpose together for the best outcome for that person. We would want the same. I think every time I talk to Dr. Downs, that's always her foremost to me is, you know, I would want that. What can I get in the best way so that I have the best outcome?
Well, there's an extreme piece of like psychosocial that nobody really talks about,
Correct.
I guess, because it's, I don't know, mildly taboo. But as a woman speaking to women, it's always addressed in my visits. I mean, breasts are important to us. They're part of our femininity, part of our sexuality, part of our capacity to be mothers. And for some people, that's important to maintain throughout this process. And that's what we're here, is to figure out, what do you want these to look like? How important is it for those three things I just talked about for you? What's most important for you a year from now, once the cancer's gone and we've done all of our necessary damage to get you through?
Right. Yeah. Well, thank you very much, Dr. Ross, Dr. Downs. I appreciate you guys coming in and talking today and giving out all of this information. And we'll also link, some of the information on our website so that people can readily get in touch, rather, with you guys. Thank you so much.
Awesome.
Thank you for having us.
Thank you so much.
Appreciate it.